Welcome to Pathways to Equity, a podcast that presents ways to make health systems around the world more equitable for everyone. I'm Nathan Blanchette, your host. I'm also the project director for the Health System Strengthening Accelerator Project. The Accelerator is a 6-year initiative which helped 17 countries in Africa and Asia improve their health systems. Through the work with these countries, we learned a lot about what makes a more equitable healthcare system. In this 3-part podcast series, we're sharing the lessons we learned working with doctors and leaders on the ground about how to make healthcare more equitable. One strategy we saw many countries using in their equity work is implementation research. Or put simply, how are you measuring if what you are trying works? In today's episode, we want to share some examples of how implementation research helps 2 countries, Ghana and Guinea, make progress toward their health equity goals. We'll start in Ghana, a country with the goal of having universal health coverage by 2030. To get there, the country needed to find effective ways of reaching vulnerable, underserved, and priority populations with high-quality services. In other words, to leave no one behind on the road to universal health coverage.
So my name is Dr. Alphonse Makafui Japasu. I'm a medical doctor. I'm practicing in Ghana.
Dr. Jack Pasu works at the Ghana Health Service. He and his colleagues used implementation research to study a new approach for implementing primary healthcare called the Networks of Practice. Networks of Practice is a solution to a big problem in Ghana, the disparities in care among different parts of the health system and different facilities in different places.
In Ghana, we have 3-tier health system. We have the CHIPS compounds, we have the health centers, then we have the district hospitals before the regional hospitals.
He says people get different care at each tier. The community-based health planning services, or CHIPS compounds, which are the most convenient type of clinic for people to easily access, often had more limited and even poorer quality of care.
Not because those down there are not willing to give health care the way it's supposed to, but sometimes because they are constrained with logistics, equipment, medications. Each CHIPS compound had to serve a community of people. But because they were all running it as individual and as silos, they couldn't meet their needs. Because if you go to certain facilities, instead of the 10 essential equipment, they may have about just 2 or 4. If you go to another facility, they may have 4 out of the 10.
Care gets more extensive and higher quality at health centers, and even better at hospitals. But hospitals can be very far away. Many patients completely skipped over the CHIPS compounds because they weren't able to get the care they needed there. That is one of the problems Dr. Jack Pasu and his colleagues wanted to address. How can they improve care at the local clinics and therefore make access to high-quality healthcare more equitable? That's how they came up with the Networks of Practice. The network connects the local CHIPS compounds into networks with model health centers that serve as hubs. The facilities share resources across the networks to improve services closer to the communities. One reason this wasn't happening before, according to Dr. Jack Pasu, is because each facility looked at itself as an island and even competed with each other.
This is one thing we found out. Before, we realized that there was this unhealthy competition among health facilities. As in, health facilities will compete, one, for numbers. We have the National Health Insurance System, which pays based on number of clients you've seen in a month. So based on that, everybody wanted to keep clients to themselves. So if I have equipment or logistics or medications, why should I share with you? Because if I share with you, then my clients will equally come to your end. So the introduction of the network of practice first took away the competition. So there's no need for competition. We tell people that we are healthcare workers, we are health facilities. Our main job is to provide quality of healthcare to the people within the community. So no need competing. The networks of practice is more to collaborate. So you collaborate in multiple activities. You collaborate in outreaches. So that if there's a health outreach within the community where you're supposed to talk to the community and offer some services. So instead of one person from facility A going to a community of 100 or 200 people to attend to them, which would be too much for him or her, 3 facilities could come together with 2, 3. So they become 5 health workers attending to about 300 people. And that brings the patient load down and improves the quality of care.
They do the same thing with medication. Doctors and other healthcare providers at different facilities communicate and send each other medicine for patients. This allows people using the networks of practice in Ghana to not have to wait or travel for life-saving medication. The network also improves communication between facilities. So if a patient does have to travel from one to the other, the receiving clinic is ready for them.
A clear example was a case of a pregnant woman. This is when I was there, a pregnant woman who was due for referral. She was in a town which was about 45 minutes to 1 hour away from our hospital. When the patient, she was, I think, was a breech presentation, so needed a cesarean. When the patient was referred to my hospital, the patient was like, "Oh, I don't have money. I have to wait for my husband," and it was getting a bit complicated. So what did we have to do? The hospital said, "Oh, since you're in the same network, send the patient over." We spoke to the driver, the transportation system. They got the patient over. The hospital took care of the patient's transportation bills, attended to the patient, delivered the baby, mother fine, baby fine. The husband came later to come and settle the bills. So that is what the level of coordination came about in terms of the referral system too. And when the referral system improved, automatically morbidities and mortality associated with maternal and child health reduced. Stillbirth will automatically reduce because cases are being referred earlier. Maternal mortality will reduce. Maternal morbidity will reduce because there's a support system to move the cases and attend to them. So that is how the networks operated and how some of the benefits of the network.
I see the picture clearly on how this should work and in theory could work. How do you know that it's actually working? And I'm wondering if you can take us into the implementation research that you were involved in. What does that mean, implementation research, and what kinds of things were you looking into through that research for these networks?
When it came to the implementation research, after some time, you want to review what you have done to see whether your activities are leading to the right impacts and for you to know whether you are doing the right thing. You know, the main purpose of the networks of practice is actually to improve on health equity, which means that everybody can receive the right care. So the main purpose of this implementation research was to see whether this agenda that we set for ourselves is being achieved. And also because the needs of human beings keep changing, we need to review and revise our policy notes to make sure that it meets the changing needs of the people within the community.
The research team used a combination of quantitative and qualitative methods to explore the role that networks of practice had on equity. They surveyed 500 randomly selected households in 2 districts about the use of health prevention and promotion services and measured 3 dimensions of health equity: wealth, gender, and geographic location. A series of questions based on something called the equity tool was used to determine each household's assets relative to national quintiles. Multivariate regression analysis was done to estimate the effect of different factors on the use of care. Qualitative methods included thematic analysis of 14 focus group discussions and 17 in-depth interviews with community members, networks of practice practitioners, and managers. This is what they found.
A few things came up very clear is that most of our clients will skip the health CHIPS component in the health centers and come to the district hospitals to seek health care. So they will skip it and come to the district hospital because then they're sure they could meet their needs. And all this because, one, CHIPS compounds in the health centers, one, didn't have the right mix of the human resource, didn't have the right mix of the equipment and logistics and medications to meet the needs of the people. And that was one main thing which the network of practice was supposed to close up and to improve on that, which shows that as much as we're trying to improve on equity, there were still some gaps within us trying to achieve equity. So the implementation research exposed that part out for us to redefine and relook at how we can achieve equity.
And what do you think were some of the key findings there that, as the Ghana Health Service looks to adjust this model and scale it up, or informing the scale up now?
The first point, of course, should be the CHIPS compound based on where you are, the health center. But as I rightly say, people skip it. So the whole purpose is to bridge that gap. So that is where the Ghana Health Service, in collaboration with the Ministry of Health and the World Bank, is revamping what we call the model health centers. So now model health centers are being created all over the country so that for healthcare, people don't have to skip the CHIPS for the health centers, but then we'll use the CHIPS in the health center as their first point rather than going to the district hospital. That is one way, one recommendation that came up and it's been implemented very well. Another thing that also came up was the mixture or the right mix of staff at the health centers and the CHIPS compound. Because if you go to a health center and there's no midwife and you need midwifery services, then you have to skip that health center to go to the district hospital. But based on the recommendations and the creation of the model health centers, a new category of right mix of staff has come up and they are doing so well. I think World Bank is aiding Ghana to employ more physician assistants at the health centers. Now there's reshuffling of staff so that midwives are found in almost all health centers, the CHIPS compound, to support this and to improve on equity.
If they hadn't stopped to ask the community for feedback, they might not have realized that people were still skipping the CHIP centers. They wouldn't have known that more midwives would address a big part of the understaffing problem, and they might not have gotten more support from the World Bank. That's part of the power of implementation research.
So it's important, very important, to keep implementation research as the bedrock and as the core part of healthcare policies, and for them to work hand in hand in that aspect. Implementation research also goes a long way to improve on health outcomes. It helps to improve on health indicators too. If you're able to quickly bring the findings out and implement the recommendations, you realize the health indicators will usually get better. But if you delay in implementing some of the recommendations, then you realize that we don't achieve much.
That's a really interesting point, and I wonder if it's one that is especially important in the health space, that things are always changing. Disease patterns are changing, populations are changing, populations are moving.
Yeah.
Nowadays, particularly with even things like climate change, you have changes that seem to be accelerating in some cases and some unusual cases. Does that make the case for implementation research particularly even more important, I wonder?
It's very important, for us to actually make implementation research like the bedrock of healthcare, because of all the changes you just said. Climate change, we are in May, it's a rainy season here, and by June it should be ending. But I think the last 2 years, there's been a lot of changes in the climate pattern. And obviously, when there's a change in climate pattern, there's going to be a change in disease pattern, because certain weathers come with certain conditions. And this actually can be picked up by the researchers. If you take our data from last year and last 2 years, if you follow the trends, you realize that there's been certain changes compared to last 4 years, 5 years. We actually looked at the trend ourselves and this thing didn't used to happen in May, June. Why is it happening now? So then we have to start making adjustment to it. And that is key to show that implementation research is a key component of healthcare delivery. If we don't pay much attention to it, then we might miss the boat. We might not be able to meet the health needs of the people. We might just have another epidemic before we even realize it.
Thank you to Dr. Alphonse Jakpasu. He is a doctor working in Ghana. Another country that recently used implementation research on a health initiative was Guinea. To explain how this research worked there, I called Dr. Alexander Delamu.
People usually call me Alex. I am a medical doctor by training. I hold a PhD in public health sciences, and I'm currently full professor of public health at the University Gamal Abdel Nasser of Conakry.
In Guinea, one of the biggest challenges to health equity is who can access essential primary healthcare services.
For instance, more than 60% of the health care personnel are working in the capital city and its surrounding health districts, where they serve less than 40% of the overall population of the country, which means that access to skilled health professionals is challenging in the countryside, where most of the population live.
Another problem, Guinea also doesn't have the right ratio of health workers to citizens. Its ratio is far below what the World Health Organization recommends, 23 health workers per 10,000 people. Dr. Delamu says Guinea has about 12 health workers to serve 10,000 residents. But the impetus for a big change in Guinea's health system came after the devastating Ebola outbreak in 2014. Guinea was hit hard by the outbreak, and the government came up with a new solution to try and improve access to essential health services and rebuild trust in the health system.
In the aftermath of this outbreak in 2017, the Minister of Health adopted a new national community health policy to decentralize the community health system by transferring responsibilities and skills to the municipal level, so to the local level. This strategy was based on community health workers and community relay. So community health workers were defined as assistant nurse by training. And these are people who have undergone 3 years of medical training. They have good command of the local language, and they can take also responsibility for all the activities that are related to their duties. And community relay who are willing to serve in their community where they live, and also there are people who can at least read and write in French and also speak the local language.
So they created a system with these two types of workers: the community relays, who worked directly with patients in rural areas. These relays were supposed to oversee 600 residents. They reported to a community health worker, a trained medical professional who managed 10 of these relays. The purpose of the community relay was
to have people who are near the community who can bring about health education and promotion, but also who can bring some health services in a decentralized manner within the community. For instance, performing rapid diagnosis tests for malaria and also providing treatment for simple cases of malaria within the community, identifying complicated cases of malaria and referring them to the nearest health facility, and also following up with pregnant women to ensure that they are respecting their antenatal care schedule, and also encouraging families to support pregnant women's delivery in a health facility or with a skilled birth attendant. So the idea was really to reduce the gap in access to care for the most vulnerable populations who live in the countryside, where sometimes it is very difficult to access health services.
So the community relays helped address and treat common health issues. But Dr. Delamou also said that the community health policy was tied to decentralizing key health system functions.
The idea was to bring the local government within the communities. And this was done by delegating some of the administrative mandate to rural communes so that they can deliver those services to the communities. In short, to simplify the life of the citizens. For instance, usually when you wanted to get a birth certificate, you have to go to the district level to get the birth certificate established. So the establishment of the birth certificate was decentralized to rural communes. So this was a way to simplify administrative procedures. So if a woman delivers to the health center, then the next day or the next week she comes for immunization, then she can go to the administrative office and then get the birth certificate of his or her child. So there were several other activities that were decentralized at a local level.
It seems like a great plan in theory, but this is where the implementation research came in. Dr. Delamou and others who worked on this wanted to see if the national community health policy was achieving what they wanted in these rural areas.
So the stakeholders agreed on two research questions. The first was to assess the extent to which local public actors know their roles and responsibilities under the community health policy, including enabling factors and also challenges. And the second question was to assess the extent to which the provision of services by the community health workers meet population's health need.
To assess these two research questions, Dr. Delamou and the research team used a theoretical framework called decision space. Decision space refers to the authority and capacities of local government officials and has two parts: what's called de jure decision space, which is the degree of choice that local officials are authorized to make, and de facto decision space, which is the degree of power that they actually have in practice. Using this framework allowed the researchers to help explain gaps between the community health policy on paper and in actual practice. They used both quantitative and qualitative analysis. For the quantitative part, the team conducted a survey of over 500 participants at all levels of the health system to measure decision space. They also did an interrupted time series analysis to see how the community health policy was associated with changes in maternal and child health service delivery indicators, such as immunizations, over time. The team also carried out in-depth interviews and focus group discussions with community health workers, community members, and other health officials and partners. So what were the results?
So we found that the reality of this policy did not often match with the policy on paper. For instance, the study results revealed that community health workers and community relay had higher levels of knowledge of their roles and responsibilities, and they also had a higher level of involvement in the implementation of their roles and responsibilities. But in contrast, the actors at the community level, such as the mayors or the heads of health centers, had lower levels of knowledge of their roles and responsibilities and low levels of implementation as compared to community health workers. So in the study, we found that the reasons for this difference might include the multiple and competing responsibilities of the actors at the central and intermediate and also community levels.
So it seems like community health workers themselves were very active, but other levels of the health system and government needed to get more involved in how this new setup should function. I was also curious if the community health policy and community health workers were really making a difference for patients who needed access to care.
We found that the implementation of the policy increased access to health services and also restored the trust between communities and the health system, which was very important, particularly given that rumors during epidemics such as Ebola or COVID can reduce health service utilization. For instance, we found that the community health strategy had an immediate and positive impact on maternal health in the areas where the policy was implemented, which was not the case in other types of comments. So our data suggests that these positive results probably related to the provision of the community packages with the financial support of partners. However, this positive trend was interrupted after the withdrawal of financial support from the partners, especially the payment of the salary of community health workers and also their equipment. And we also found a negative impact of the COVID pandemic on the use of services. So our findings highlight the importance of a reliable financing mechanism to ensure that the implementation of the national community health policy is maintained. So this means that we need continued financial support from the government and also from partners. And this support is crucial to maintain the quality but also the continuity of community health services.
This implementation research led people in the government of Guinea to make some policy changes. The hope is to better this program and reach more patients in rural and underserved parts of Guinea.
In terms of policy, the evidence we generated was used to inform the development of the new national immunization strategy, which ran from 2024 to 2028. And also it informed the development of the new national community health policy running from 2023 to 2027. This was very important because in the new policy, the Ministry of Health and its partners were able to refine the roles and responsibilities for the actors that are involved in the community health program. They were also able to include activities related to identifying capacity strengthening areas for actors at different levels of the health system and in the regions. So the second aspect was advocacy. So here the findings were used to support advocacy for the adoption of a new law on local civil service. And this law includes the payment of community health workers' salary by rural communes, so rural governments, through an agency that is established in the country and called the National Community Financing Agency.
Dr. Delamu and others in Guinea hope these changes can make access to community health services more equitable by reaching more patients in rural areas. The advocacy that Dr. Delamu refers to was carried out by civil society organizations using findings from the research. In the next and final episode of Pathways to Equity, we'll talk about how engaging with civil society organizations is another strategy that is helping governments improve health equity. Pathways to Equity is a production of the Health System Strengthening Accelerator, funded by USAID. You can learn more about the Accelerator's work at our website, acceleratehss.org. That is linked in our show notes. I'm your host, Nathan Blanchett. The rest of our team is Melanie Morrow, Leor Miller, Elle Catron, Alexander McCall, and Nikem Wellington. This podcast was produced by Claire McInerney. It was mixed and mastered by Megan Palmer.